HOD Professor Pandey is also joining.
Good evening, everyone.
प्रणाम सर। अच्युत।
प्रणाम HOD साहब।
अभी ओपीडी में चल रहा मामला सर।
अरे अरे वेडनेसडे का ये हाल है, ओ माय
क्या
गॉड।
करूं, आपसे होता नहीं। आपने वो वाली विद्या हमको दी नहीं जो एक्सरे वाला सब मशीन
सब
सामने देख ले। हैं?
सब
हम
कुछ
तो
दे दिया जाए।
हेलो।
जी सर। ठीक है सर, मैं म्यूट कर रहा हूं अपने को बस।
हाँ हाँ ठीक है, आप वीडियो भी ऑफ कर सकते हैं, नो प्रॉब्लम। बट
नहीं नहीं
स्टे
सर, अभी
ट्यून।
तो हूँ, जब मैं यही
हाँ
पे
हाँ
सुनता रहूंगा, कोई दिक्कत
हाँ एकदम से। बट कंफर्टेबल, बट
नहीं।
प्लीज रिमेन लिंक्ड,
जी जी जी
ताकि,
सर।
है ना।
जी सर।
Good evening, everyone. Respected teachers, senior professors, colleagues, postgraduate residents, students, and all mental health professionals joining us today. Welcome. I'm Dr. Shaurya Singh. I'm the senior resident in Institute of Medical Sciences, Department of Psychiatry, BHU. So, it is my privilege to introduce Revisiting Psychiatry, a webinar series beginning from 13th May 2026, that is today, under the guidance and academic leadership of Dr. Professor Sanjay Gupta, Department of Psychiatry, Dean, IMS, BHU. Uh, Before I formally introduce the series, let me begin with a very common situation that we as resident trainees face on a day to day basis. Uh, just a situation where a patient walks into the OPD, there is irritability, guarded behavior. uh, and treatment succeeds only when it becomes practically important. It helps us to relationships, financial realities, cultures, and environment. So, me explaining all these or me trying to talk about all these scenarios, we may know these things, we may have a sense about these things, but still, the application part of it, maybe we can work on it a better by revisiting certain concepts. So, this is one of the central ideas behind revisiting psychiatry, a brainchild of our respected Dr. Professor Sanjay Gupta sir. So, it is about revisiting how we think, how we listen, how we observe, how we formulate, and ultimately how we understand the human suffering with greater clarity, empathy, and clinical wisdom. So, equally important, it helps us to translate complex situations into a simple, uh, into simply helps us to translate it into simplicity or simple situations. Uh, at the end of the day, it is more to do with a concept that insight can be meaningful only if it is understood, and treatment succeeds only when it becomes practical in the patient's real life. This series aims to revisit psychiatry not as a rigid system of labels, but as a discipline rooted equally in science, observation, communication, and humanity. So, we hope that these discussions will encourage residents and mental health professionals to think more deeply, to engage more broadly, and to be more thoughtful and aware when discussing these symptoms with the patient. At its core, psychiatry is not merely about identifying disorders, it is about understanding human experiences in context and responding with competence, empathy, and balance. So, on the behalf of all the juniors, all the residents, I would like to show my gratitude. I would like to extend my sincere gratitude and respect to Dr. Sanjay Gupta sir for his academic vision, mentorship, and continued guidance in shaping this initiative. Thank you to all the members, all the colleagues, residents, seniors for joining this session today. So we would basically be discussing about a case vignette, wherein we would also try to engage in a more dramatic or storytelling manner by giving you a scenario, and then we will try to discuss on the concepts that we as psychiatrists or maybe as trainees or just graduated psychiatrists, suppose like me, have been taught or trained over the years. But what else can we ponder upon? What else should we look into? What else should we think uh, with regards to the psychosocial situations? The patient, more so the person in context, and how all those situations have affected that person. This is also important and may will also help us to get some ideas on how to modify our treatment so that it is in a holistic, integrated, and empathetic manner. So, with these words, I would like to begin the session, and throughout our session, we will be guided by our respected uh, sir, Sanjay Gupta sir, and there would be an open discussion about whatever people would like to uh, extend their people would like to share or express their opinions or express their views on how to manage the case and how to work forward. So thank you all again, and hope we have a wonderful session.
Thank you very much, Dr. Shaurya. I think we have the HOD Psychiatry Professor Pandey with us.
Yes, sir.
So you can ask for his blessings.
Yes, sir. Good evening, sir. There's some glitch in connection.
When Worry Became the Villain. Chapter 1. The Girl Everyone Mistook for Strong. At 20, she stood in that uncertain space between adolescence and adulthood, where everyone expects certainty before anyone truly understands themselves. She was in the final year of her BA degree, known among others as sincere, soft-spoken, and emotionally perceptive. She felt everything intensely. Disappointment lingered longer, criticism cut deeper, and comparisons stayed long after conversations ended. People often admired how quietly she carried herself. What they failed to notice was how much weight silence can hold. For years, she had learned to survive emotions by containing them rather than expressing them. Stress did not leave her easily. It settled within her, gathering slowly in unseen corners of the mind. Most days she managed until the final year began, asking more from her than she knew how to give. Chapter 2. The Weight of Falling Behind. It began with a single academic backlog. To most people, it was temporary, an inconvenience, a delay, something eventually forgotten. To her, it felt heavier than that. Around her, friends spoke about internships, examinations, future cities, future lives. Their certainty became a mirror in which she saw only her own hesitation. They failed her paper, did not merely wound her confidence, it altered the rhythm of her thoughts. Questions began repeating themselves in quiet moments. What if she was failing behind? What if this became permanent? What if disappointment became the only thing waiting ahead of her? Her thoughts kept returning to the same fears until even ordinary days felt exhausting. What began as quiet worry spread silently through her mind like an unnoticed growth, the whisper of worry. Chapter 3. When the mind learns the language of the body. Soon the distress dropped, remaining emotional alone. A dull headache began appearing across her forehead, lingering through afternoons and stretching late in the evening. It was never violent enough to alarm anyone, yet persistent enough to slowly exhaust her. The strange part was how closely it followed her thoughts. The more she worried, the heavier it became. There were no dramatic symptoms, no blurred vision, no nausea, no visible illness, yet her body seemed to be speaking a language her mind had ignored for too long. Around the same time, sadness began entering quietly into parts of life that felt effortless once. Conversations became tiring, laughter required intention, even rest no longer felt restful. Anxiety threaded itself through her routines while studying, while eating, during conversations, and most noticeably at night, when silence gave her thoughts more room than they deserved. Sleep shortened, appetite faded, restlessness replaced stillness. From the outside, very little had changed. Inside, however, she felt herself slowly becoming unfamiliar to her own mind. Chapter 4. The weight she never spoke about. There was another shadow living quietly inside the house. For more than a year, her father had been drinking regularly. Nobody named it aloud, yet everyone had learned to live around it. Around the shifting moods, the uneasy silence, the unpredictability that seemed to linger in the walls long after the nights had passed. Home no longer felt entirely steady, and she, as always, absorbed the unrest quietly. By then, the pressures in her life had stopped arriving one at a time. Academic failure, fear of being left behind, emotional vulnerability, and growing heaviness at home had begun tightening around her together. Like threads slowly pulling into a knot she did not know how to untangle. She had spent years surviving distress by burying it beneath silence, but silence has a way of turning pain inward. And somewhere within her, the whisper of worry was no longer whispering alone. Chapter 5: The Exhaustion Beneath the Surface. The following weeks felt different, not sudden, not catastrophic, just slowly unbearable. She still looked functional to the world around her. She answered questions, sat through conversations, moved through familiar routines with practiced normalcy. But inside, something was beginning to wear down. Her thoughts no longer rested quietly. They crowded her mind from morning until night, each fear feeding the next, until even simple moments became exhausting to move through. Confidence slowly gave way to doubt. Rest gave way to restlessness. Even silence no longer felt peaceful. Then her body began carrying what her mind could no longer hide. The headaches returned daily now, dull, pressing, persistent, spreading across her forehead like a weight she could never explain nor escape. The more her thoughts spiraled, the heavier the pain became, as though her mind had started carving its distress directly into the body. Sleep shortened, appetite faded, laughter became effort instead of instinct. And the strangest part was that almost nobody could truly see it. From the outside, she still looked like herself. Inside, however, she felt as though she was disappearing piece by piece. Beneath the constant pressure of her own thoughts, her parents noticed the change slowly, the growing silence, the withdrawal, the tired eyes, the worrying that never seemed to stop. It was no longer something that could be dismissed as stress. That was when they brought her to the OPD. Chapter 6: Naming the Storm. The assessment searched for answers, but what it uncovered was far more complicated than a single diagnosis. Her distress did not move in straight lines. Anxiety bled into sadness, sadness into exhaustion, exhaustion into physical pain. Her emotions shifted with stress and overthinking, rising and collapsing in waves that left her mentally drained and emotionally unstable. Several possibilities were explored: anxiety-related conditions, depressive symptoms, dissociative features, vulnerabilities rooted in personality and coping. But beneath every observation lay the same truth. This had not begun recently. The roots stretched much further back than the backlog, further back than the headaches, perhaps even further back than she herself understood. For years, she had carried emotions too deeply and expressed them too little. Stress was never released. It accumulated quietly inside her, layer by layer, until her mind no longer knew how to carry the weight without breaking under it. What others called sensitivity had slowly become exhaustion. What she called overthinking had slowly become fear. And somewhere in that slow collapse, the whisper of worry had spread through her life unnoticed, silent as an unseen growth, tightening itself around her thoughts long before anyone realized how far it had reached. Chapter 7. The Breath That Interrupted the Noise. During therapy sessions and supportive sessions, she learned something she had never noticed before. Anxiety changes the way a person breathes. Without realizing it, her breaths had become shallow, hurried, and tense, as though her body had forgotten how to exist without preparing for danger. Even in moments of stillness, her mind remained alert, unable to fully rest. That was when deep breathing techniques were introduced. At first, it felt almost insignificant, too simple to matter, against thoughts that had grown so loud inside her mind. But gradually, she began practicing the deep breathing techniques nicely, and slowly something within her began to loosen. The headache softened when her thoughts slowed. Her body relaxed during long, careful exhalations. Sleep became slightly less distant. Moments of panic no longer consumed her as completely as before. Deep breathing did not silence the whisper of worry overnight, but for the first time in a long while, its voices no longer felt impossible to interrupt. Chapter 8. Learning to Carry Herself Differently. For the first time, she stopped seeing herself as broken. Instead, she began understanding that sensitivity is not weakness, that stress can manifest physically, that coping skills can be learned, and that setbacks are not permanent identities. Her backlog was still there, her challenges were still real, but now she had tools: awareness, emotional expression, breathing control, healthier coping mechanisms, and support. The villains no longer ruled her story. Her greatest battle was never against academics alone. It was against the storm of worry, comparison, and emotional overload that slowly convinced her she was falling behind in life.
Hello, good evening, all. Uh, we have with us our head of department, Dr. Achyut Kumar Pandey, sir. We would like to thank him and take his blessings while going forward through this webinar. Sir, if you could just say a few words.
I think somewhere along the line he's muted, so you can carry on.
Oh, so now we will just continue with the video depiction of the case. We discussed the case in a very dramatic and in a very storytelling manner. So now the standard format we were in we present cases and we depict cases. So I would request Dr. Vaishnavi to continue with the presentation, the video presentation.
The voice is not coming. Vaishnavi, you're muted. Dr. Vaishnavi, you're muted. Please start again.
Good evening, everyone. I'm Dr. Ayush Balot. I'm going to present the case of the patient present whose story and appetite. Good evening, everyone. I'm Dr. Ayush Balot. I'm Good evening, everyone. The case I'm of the patient present whose story has been told earlier. She's a 20 years old BA final year student accompanied by her parents presented to the OPD with complaints of headache, sadness of mood, anxiety, anhedonia, decreased sleep and appetite, worry about academics for past 2 years. On detailed interview, headache was found to be dull aching, constant type, mostly throughout the day on bifrontal region, not associated with nausea, vomiting, photo or phonophobia or blurring of vision. It increased on overthinking. Sadness and decreased interest in activities were present on and off, mostly during worry. She had a back in her final year paper and was feeling sad as she was behind her friends and would feel low worrying about the same. She also had an episode of fainting about 7 to 10 days back, characterized by loss of consciousness lasting for about 40 to 50 minutes, not associated with abnormal body movements, frothing and bleeding from mouth, urinary and fecal incontinence, uprolling of eyes, skipping of breakfast happening before the OPD consultation in the morning, few days before her results had come out, and she was anxious and worried related to the same. Past history, she had episodic anxiety with somatic symptoms and worry, along with episodes of paroxysmal event with no abnormalities in EEG. The onset was around 19 years of age and good response to psychotherapy, which was domain based, and relaxation techniques along with paroxetine 25 mg and amitriptyline 12.5 mg. Compliance was fine for medications but could not practice relaxation exercises or attend counseling sessions regularly. Pre-morbidly, she had increased sensitivity to emotional distress and poor coping skills. Her family history in alcohol use in father, regular use since more than a year. Routine investigations were normal except for hemoglobin, which came out to be 11.61. Summary points are these symptoms are not persistent, and pre-morbid personality is a predisposing factor. And MSc findings doesn't reveal anything significant as symptoms are not persistent nearly all day, which is the diagnosis criteria for depression as per DSM-5. So a dilemma arises in this case, which is what to do, what medicine to give, and how to proceed. So let's move on to the need for a valid assessment, which is SSDQ. Now handing over to my colleague for explanation of SSDQ and management of the case.
Okay, so thank you very much, Dr. Ayush, for the presentation. Now I would request Dr. Vaishnavi to open some slides that I would use to explain the assessment that we used in this case. Okay, so first of all, what is the need for this assessment to be done? So, as we could see in the summary of the case, there are no symptoms that would fall into any of the diagnostic criteria. The symptoms seem to not be persistent or generalized. That most oftenly, like we see in DSM-5 criteria, it mentions that the symptoms should be present nearly all day, whether it be major depressive disorder or other disorders like anxiety disorders. The symptoms spanned over a period of 1.5 years, got exacerbated in the recent past month, but they were just on and off. So in the OPD settings, we use something that we call SSDQ. So it basically is a student stress domain questionnaire scale. So it helps us to understand the cumulative stress load. So the graph here actually presents 10 domains in the on the x-axis, as you can see, from physical interpersonal, personal, social, behavioral, familial, to the end one is mood and thought and emotion. So, what are the domains affected in this case? And then, apart from that, the independent stressors. So, this questionnaire has a set of 93 questions, wherein you score it as 0, 1, or 2, with the criteria being 0 being almost none, 1 being sometimes, and 2 being almost always. So, further, I would like to move ahead in the slide. Like, okay, so these are the major domains that you could see. You could see more than 40% of these domains are affected. So we have other scales to mention stress, but the common daily stresses, or the stresses that we usually see in daily life, which add on and they form the cumulative stress load, are being depicted here. Can we move ahead? Okay, so now in the middle there, you can see that there's something which is known as independent stressors. So these are those points wherein there is a score of 2 on the questions. And there's also a validity test that we do in these questionnaires. Like, we randomly ask 5 questions and we evaluate whether the patient understood how to answer and how to go ahead with the questions. So now we would look at the independent stressors. Okay, so basically, the questions actually point out to these factors. Like, uh, they can be grouped into these factors, like lack of stable friendships, boredom, unstructured routine being present. It all goes towards loneliness. Then emotional fragility, represented by crying spells or anger outbursts. Then the bodily manifestations of anxiety that we usually see, like fatigue, tremors, physical tension, body ache. Okay, so basically now, the need for doing this assessment and the way to move forward, like, management being focusing the intervention focusing on selected independent stressors, and being very targeted. This is especially useful in a very busy setting, like a medical college in a city like Varanasi, or in any other city where the OPD has a lot of patients, and dealing with such cases becomes slightly difficult because of the time involved. So you can see the different approaches that can be taken. Simple approaches, but useful approaches. Along with that, the technique of deep breathing exercises that would help the patients to go through with the anxiety, the relaxation exercises, the awareness about it, and the psychoeducation. So this was the way forward, moving ahead with this case, and not merely looking at the biological component, but looking at the psychosocial aspects also. So now I would request Sir to join the conversation and give his views on the case and on the management of such cases.
Uh, yeah, thank you very much. I was just thinking that the type of independent stressors that were found in this particular case. So, what were the particular independent stressors which were specific to this case? I mean, the independent stressors are the stressors which the person is very, very heavily concerned about. So, can anybody shed light on that?
Okay, so
You showed a slide, I think, in
yeah,
which you mentioned some
yes.
issues.
So, yeah, Dr. Ankita, would you like to comment on some of the stressors you found in this patient? Like, we came to know about, we grouped certain symptoms on the basis of certain questionnaires that we found to have a score of 2. So, what were the major stressors that could be elicited in this patient, like the independent ones?
sir.
Hello.
And- Okay, sir.
I think Bhanupriya is also with us. Ankita,
Yes, sir.
yes, Ankita, just some of the things that were specially, which could not be found on the interviews, which were found on the SSDQ assessment.
Good evening, sir. I would like to mention these independent stressors. Certain stressors were present in physical domain and some were present in mood and thought and behavioral domain also. First stressor is fatigue. Used to get fatigued easily. She used to feel anxious whenever she dealt with that situation. So she used to feel body tension and physical stress. So she used to have anger outbursts. She used to get bored easily, says she was not able to have her optimum functioning due to the gloomy she used to feel. She has very less number of friends. She, fre- frequent changing of room partner, which needs to be addressed. So she has a lot of loss of interest sometimes, which is not consistent. And she used to have a crying spells, mostly concerned about stressor. And she used to feel lonely. She used to have a frequent mood change. These were the independent distresses which we were able to elicit
So
using the
these,
interview.
so these frequent mood changes,
Yes.
they would not come under mood dysregulation syndrome or any bipolar disorder or something like that.
Uh,
No.
yes, sir. Yes, Dr. Shivam, you can continue.
Yes, sir. They does not feel that criteria for any disorder. Sir, they are mostly related to stress only. If she
Yeah,
feels
so this is precisely. I think I think I'd like to really compliment Dr. Shaurya, Dr. Shivam, Dr. Vaishnavi, Dr. Ankita, and the whole team, because I think you showed a case which is a very regular feature, and just offhand, what is done is. Even if the person is not uh, fulfilling the diagnostic criteria, we go on to give antidepressant drugs. So, antidepressant drugs are absolutely contraindicated when there is no when there is no condition. And in fact, many of the times, what we feel is this sort of things by non-specialists are ruining the whole fabric of the mind, because before the person comes to the psychiatrist, many of the patients who do not need any antidepressants, they're just having a lot of stress, which is a very common feature these days. They're having a lot of stress, and they go to some non-psychiatrist, and they just prescribe irrationally antidepressants. So this leads to, maybe later on it could end in it could induce a manic syndrome or things like that. And these mood swings and all, I think after the SSDQ, what is done is the independent stressors. That is, what is there. If the person has less number of friends, then you can say that there is social dissatisfaction. So, what in psychotherapy, what you could do is, target that. You cannot increase the number of friends. Sitting in your clinic, you cannot increase the number of friends, but then that that is a problem. So you can tell, maybe you can develop some hobbies or something else. Then you can give some tips like those. Many of the times when the person has less number of friends, underlying there is social phobia, and that is to a very mild level. But then you have to look for it, and the minute you look for it, many of the times, if the person is having stress, you're just going into depression. But if you look for it, that mild social phobia will result in the person not going out with friends, going not meeting friends. So the person is lonely, and as the WHO has now said, loneliness is itself a big problem. And it's time that psychiatrists look at loneliness alone and try to target that. And I think the rationality would be that if such a person over 2 years, naturally you would say that it's over 2 years, so it's a pattern of continuous stress. So the lifestyle modification, the separate those personality traits that are coming in, the independent stressors which are not which are coming into her not performing to capacity. I think once you target them in the OPD, and in the OPD it becomes easy, like you said, using the student stress dimension questionnaire. I think it takes 20 minutes. So 20 minutes, the person fills it up. The next 20 minutes, the resident takes it up. And in our place, in the Department of Psychiatry, the Professor A.K. Pandey is with us. He's the HOD. We are continuously doing this for many years, and we've found tremendous results. So I think it's time to revisit the way that we are looking at things, because maybe 2 years, Dr. Shaurya, you said 2 years. So 2 years की history आप जब लोगे, so what we usually do is we ask ये 2 साल पहले क्या हुआ था. I think that's a very funny concept. I mean, it's very easy to ask anything, but any one of us who is in this webinar, if I ask any of you 2 years ago what happened, I don't think anybody will be able to tell. But we ask the question, the attendant responds also, and we put it on the file. सब हो गया, सब अच्छा है. साहब 2 साल पहले ये था, 1.5 साल पहले ये था. The question of reliability, it always has to be taken. Whenever we say history, always have to comment on reliability. And in such a case, the reliability will be very, very poor. So you look at the present state of the mind. And of course, I think you'll have to follow up this person, because this chronic stress that is there will require multiple psychotherapeutic sessions. And as long as those sessions are regular, I think the outcome, as Dr. Shaurya said, I think the outcome is going to be much, much better than the ordinary profile of treatment that we're giving. That the person walks in and, okay, 2 साल से आपको दिक्कत है, okay, adjustment disorder. 2 हफ्ते से आपको दिक्कत है, major depression. And ये दवा लीजिए, 2 हफ्ते बाद आइए. I mean, it is very, very superficial. I think we have to revisit this concept. I think, psychiatry, if it is to show that it is very deep, you have to show that you have done a very deep evaluation. So I think that time has come, and not just because of a fear of the courts asking us for a detailed history or a detailed explanation or something. I think we understand that, it was said in the beautiful video that was shown of the girl, that human suffering lies in the mind, and many of the times the person cannot express that suffering or agony or distress in words. So um, I'm very thankful to Dr. Shaurya and Dr. Shivam, Dr. Ankita, Dr. Vaishnavi for bringing up this point. And the whole concept of bringing and revisiting psychiatry is we're doing everything, but there are always, what we call refresher courses or orientation courses. Uh, Updating and upgrading is always very important. What the mobile that I have in my hand, if I don't upgrade it, if I don't update it, then it won't work. Similarly, I think the psychiatrists of India, they have to keep on updating themselves. And I think Dr. Shaurya and the team has started, uh, इन्होंने bugle बजा दिया है कि this is how we have to start to do different things. And I think you're developing an app on the SSDQ questionnaire. So I think that app will be available. So many of us who have joined from different parts, different medical colleges, they can approach for the app, and it's very simple to do.
Okay, I would like to thank you so much for your views and the guidance that you provided us throughout this session. We look forward to join you again to revisit other concepts and modalities that we need to look into and maybe evolve with that, so that it suits our settings and helps us to move forward and look into psychiatry as an experience rather than just focused on books or texts. Thank you, sir. Thank you so much.
Thank you all for joining also, and thank you for tuning in. Revisiting Psychiatry will be on Wednesdays, and we'll let you know. We'll send you the link, and let's let's bring the change. Thank you, everyone. Good night.
Thanks.
Thank you, sir, for your valuable insights.
Thank you, Dr. Shivam. Wonderful work. And Dr. Ankita, beautiful video. That was wonderful video. And I think you keep the thing going. We had Dr. Vinod Verma also joining us from Jaunpur Medical College. He's the HOD there. And we had many other doctors who are in private practice. They've also joined. Thank you very much again. Good night, everyone.